You're live.
Okay, so yeah, we'll just start with the elbow exam. As kind of continuing on with our course. There's some good resources for elbow in general. The most important resource is on the left. Bernard Mori has truly the Bible of the elbow. It's an amazing volume. It's probably $300-400 in cost, so it's an amazing resource. But I mean, it's multitude. There's many editions. This is the third edition that I have and whatnot. But it's clearly the best book on the elbow that I have in my library, and the best resource for most people, be it orthopedic surgeons, physical therapists, occupational therapists, anybody working with the elbow hand, that area. There's amazing chapters on fracture management and many of the things that you see. The book on the right is that's the first book I ever wrote, and it's The Elbow in Sports, so it's only sports medicine related. And some of the things, many of the slides and pictures and things that I'm talking about here come directly from our book. So when we talk about clinical exam of the elbow, we're going to kind of approach this today as part of this course as a continuation of what we would do. We know that we would evaluate the scapula quite extensively, we'd evaluate the shoulder, we'd evaluate the cervical spine perhaps, that it really isn't truly exam of solely the elbow, but as we present it in a course like this, these slides are going to represent a lot of the specific things that we do truly for the elbow, and that's how we're going to kind of progress it. So some of the things when we see a patient with elbow dysfunction or elbow injury is to really localize the injury, because so many times, particularly in young athletic individuals, they'll say, oh, I have pain along the lateral aspect of my elbow. But really, when you manual muscle test them or you examine their shoulder, you can actually provoke that pain in the elbow by provoking their shoulder. And we see that a lot because of deceleration forces and things like that, where the pain actually refers to the elbow, and yet they don't actually have an elbow problem. Likewise, we see older individuals that maybe have a car accident or some type of neck injury, and they have pain in their elbow, but it's really coming from their cervical spine. So it's very important to try to localize with our questioning to see, what kind of history do they have? Is it something specific to the elbow, or is it very plausible that it's maybe something referred from the shoulder or the cervical spine? Numbness and tingling into the distal aspect of the extremity can happen with elbow injury, even with lateral and medial epicondylitis. The neural structures are very, very closely associated to the tendinous insertions on the medial and lateral epicondyle respectively. And so it's not atypical for that to happen. However, the atypical referral patterns would be the entire hand, continuous numbness, motor loss. Those things usually don't happen with most of our musculoskeletal elbow cases. Obviously they can in some very severe cases, but understanding the difference between typical referral patterns and non-atypical will help us to rule out who we can treat and who we can't treat for an elbow. The other thing that's really important, this little comic, if you can't read it, just says, how can I treat a lacrosse injury when I don't understand how the stupid game is played? And that's something that, quite frankly, it's a bad attitude, and that's why I thought it was funny to put in here, is that we have to know how games are played. We have to know about bowling, for example. You brought up the question earlier about bowling. If we don't know about bowling, we have to be able to film that, or we have to be able to evaluate that in some way, shape, or form, or refer them to somebody who does. So oftentimes our tennis players, when we really evaluate them, we find that there's something that they're doing apparent in their stroke mechanics on their forehand or their backhand that are actually leading to their elbow problem. And in doing that, or in having that particular problem, it can be ameliorated a great deal by just using proper mechanics. That's a really, really big part of it. So I think that's something to understand. Sport-specific questions. Obviously, somebody like Randy who works with hockey is going to understand a lot more about something specific to how they hit a slap shot, or how they do some type of stick handling, or something that happens in hockey than I am going to, because I don't really treat that many hockey players and things like that. So I think the more we can know about particular sports and understand the role that it might play is certainly really important. So the objective evaluation, some of this will look very similar to what we talked about with the shoulder, because it is really similar to what we talked about with the shoulder in many ways. Posture is a big deal, because the scapula is if you will, the anchor of the upper extremity. And so we want to use many of the scapular tests. We want to look at the position of the shoulder relative to the opposite side, the scapula, look for atrophy in the infraspinous fossa, all those things that we talked about. We also have neurovascular tests that we should ultimately probably include, and things of that in that classification are things like the Adsons and Allen tests and some of the thoracic outlet tests, because obviously somebody who has pain through the elbow into the distal extremity, we would want to rule out those kinds of proximal causes, and that would be an important part in the sequencing, and we'll talk a little bit about that. Neurological testing, extremely important. If there's numbness, tingling, loss of sensation, things like that, certainly even using, how many of you use a Semmes-Weinstein, like a monofilament kit? We have one of those in our clinic. We use that a lot with our elbow patients, because oftentimes after elbow surgeries and surgical exposures about the elbow, they're left with certain patches of sensation loss. And so to be able to quantify that objectively is very, very important, and the monofilament kits can actually be a big help to us in therapy. Range of motion and strength testing, we'll talk a little bit about that. Some very specific things about palpation, because that's something I think the literature helps us, or at least has helped me as a clinician, to be able to better identify tendinous structures by understanding where they insert on the, particularly the lateral epicondyle. And then we'll review the special tests, and we'll go through a little bit of a lab together to look at what are these special tests. So as far as our posture evaluation, I talked about essentially all of these yesterday that are on the top. Looking at shoulder heights, infraspinatus atrophy, winging and provocation tests. We won't review that in this talk, obviously, as we just covered that yesterday. Tennis shoulder definition, we talked about tennis players being more protracted, having that depressed and downward rotated shoulder, or scapula rather. Elbow flexion contracture, that's really the first mention of this. And the idea here is that when you look at tennis players, for example, on their dominant side, and throwing athletes on their dominant side, there oftentimes is a flexion contracture of about 5 to even 10 degrees. And 5 to 10 degree flexion contracture usually isn't treated as an abnormality, but normally treated as an adaptation. And I know we could sit around and debate whether it's a positive or a negative adaptation. That's open to certainly discussion and certainly research. Many people feel that it is an adaptation, in that it helps to decelerate the olecranon from entering the olecranon fossa at full extension. So it prevents that hyperextension during a high velocity movement and actually protects the posterior structures of the elbow. Some people feel that it's nothing more than a soft tissue contracture of the anterior capsule, as well as some of the anterior musculature that limit elbow extension range of motion. But nonetheless, it's a very simple measurement with a goniometer to compare bilaterally, realizing that the literature is full of studies that do characterize a throwing athlete or a tennis player with a mild loss of elbow extension. Now, is it a loss of 30 or 40 degrees considered a normal adaptation? Definitely not. And we know from the ligamentous structures, which we'll talk about in a very short minute, we know that when you can't achieve full extension, that some of the medial structures of the elbow, the medial intercollateral ligament, has to bear a greater load because the capsule and the tension of the bone, or the stability of the bone that's afforded in full extension, is not present in somebody with a fairly vigorous flexion contraction. Carrying angle. Carrying angle is normal. It can be documented just like a Q angle in the lower extremity. And carrying angle is something that is variable. We'll talk a little bit about some of the normal values and stuff like that. And then I'll show you a picture of gunstock deformity, because sometimes you'll see somebody who's had a prior distal humeral fracture that gives them cubitus varus. So gunstock deformity is cubitus varus, and carrying angle is cubitus valgus. And we see all different angulations when we examine somebody. This is a gunstock deformity right here. You can see that the elbow is actually going in a varus direction. And for those of you that may be hunters, I know that probably isn't something that's popular in Missouri, but for those of you that are hunters, that's why they call it a gunstock. It looks like the stock of a rifle, of an actual gun, and so it's been called a gunstock deformity as cubitus varus. This is King Kong arm, which is also very common in tennis players or throwing athletes. The player on the left is now he's probably a 50-year-old individual who's an announcer in tennis, but his name is Jimmy Arias, a very famous young tennis player many years ago. And you can see the difference in the size of the arm. And so back in the days of one-handed backhands in tennis, for example, when people hit basically everything with one arm and the other arm didn't do anything but toss the ball on their serve, we saw a much greater preponderance of just massive unilateral dominant extremities compared to the contralateral side, and that's what you see there. The young man on the right of the screen, you see with a resting flexion contracture, and his father was a Cy Young Award winner in Major League Baseball, a pitcher, and this young man from the age of about 6 years of age has been a pitcher, trying to emulate his father, and is very successful playing college baseball. and actually this is a very old picture. He went on and played in the major leagues as well as an adult. But even at this young age, and at this picture, he's probably about 16 years of age. He's got a fairly healthy flexion contracture on his right side. So elbow hyperextension, range of motion, is also a component of the Bateman's hypermobility index, and so that's something to watch for, and it does have implications as far as whole body hypermobility as well as specific to the elbow joint. That somebody with hyperextension obviously has looseness and laxity within their ligamentous structure of their elbow, and certainly it may have ramifications for stability when we go forward with treatment of many elbow conditions. Again, many of our patients that we see with elbow disorders are very hypermobile. This is hyperextension of the 5th MCP joint, as you see, which again is part of the Bateman hypermobility index that we talked about yesterday. Related referral joints, it's very important with every elbow patient that we see, particularly those with atypical radiation radicular symptoms, for example, or neurologic symptoms distally, to be sure that we clear the cervical spine. And by no means are we going to go through a lot of detail in this course, but this is where obviously our training with the cervical spine is of great importance. And so cervical spine overpressure and different cardinal planes of motion are indicated, as is compression and distraction. And then the Sperling's or quadrant test, which is extension, ipsilateral, lateral flexion, and same side rotation or ipsilateral rotation as well, is a bit of a foraminal closure which can provoke the cervical spine or a nerve root which may mimic their symptoms. So obviously if the patient is complaining of let's say medial or lateral elbow pain, and we put them in this position with a Sperling's maneuver and that replicates their pain, we probably don't have to go much further with an elbow examination. Their pain is probably coming from their cervical spine, in which case there really isn't any point in treating the elbow locally. We need to direct our treatment to the cervical spine. Glenohumeral related referral joints, very important to, again, rule out instability in the elbow, in the shoulder. This would be very easily done with an MDI sulcus sign and perhaps our anterior-posterior translation test, as well as a quick impingement test, just to be sure that the pain isn't provoked. There's many times that we'll examine particularly young throwers, or even older throwers for that matter, run them through impingement tests, and in the course of doing an impingement test, have that aggravate their elbow and recreate their elbow pain. In those cases, we want to do a very detailed shoulder examination, because it's very, very common in our hands that the pain in the elbow is actually coming from the shoulder. And it may sound atypical, may seem very far-fetched, but it actually is a very common occurrence, people coming in with a complaint of lateral arm or brachial pain extending into the lateral epicondyle with referral symptoms that come from the shoulder. So being thorough, as we are, as therapists and whatnot, it's very important to include this part in our evaluation. A quick word about thoracic outlet, and this is obviously something that we're understanding more and more. They can be very challenging patients with very atypical symptom presentations and whatnot. Rayan and Jensen in the Journal of Shoulder Elbow Surgery, a very old study, now 1995, talked about some of the provocative exam maneuvers that we do for thoracic outlet. Things like Adson's test and Allen's test. You can see the picture there of Adson's test, where you palpate the radial pulse, and you take a deep breath in, you provoke through the cervical spine motion, and then while holding the breath, you palpate for the radial pulse diminution or the presence of neurologic symptom. And what Rayan and Jensen found in their paper was a very, very high false positive finding among normal volunteers in the vascular component of the thoracic outlet test. So just because somebody has a diminution of pulse oftentimes doesn't mean that they truly have thoracic outlet. But if reproduction of neural symptoms, the false positives were very, very small with these particular tests. So the take-home message, even from this very old study in '95 with Raymond Jensen, is that as we do these examination maneuvers, if you provoke neurologic symptoms, that may be cause for more concern than if you have diminution of the pulse. And obviously we would couple these neurovascular tests along with other types of tests like nerve conduction velocity tests, cervical spine, imaging, those types of things, MRIs, to be able to come to the true identification of somebody as having thoracic outlet. But it is a very important thing to keep in mind in our diagnostic sequencing when we're evaluating somebody's elbow. As far as reflexes, obviously this can be very important, particularly again with the patient following some type of atypical referral pattern, or when there's some question that it may be a non-musculoskeletal type of derivation to their elbow problems. And We got the biceps, the brachioradialis and tricep, and then I already mentioned the information about the sensation. Elbow range of motion, if we looked at Kapanji's classic biomechanical work, elbow extension flexion is from 0 degrees to 140 or 150, depending on the resource that you read. About 85 degrees of pronation and full 90 degrees of supination. Wrist extension flexion is rated at about 85 degrees in both flexion and extension. And it's a relatively reliable joint, the elbow for extension flexion, relatively reliable joint in the goniometric literature. Shoulder internal rotation is very challenging. Pronation supination can be very challenging, but elbow extension flexion is actually very well documented and pretty well supported in the literature. I mentioned this a moment ago with baseball players. This is a Wright study from 2006. They found an average of 7.9, let's call it 8 degrees of flexion contracture in the dominant elbow of Major League Baseball players. In our elbow stress radiography study, which we'll talk about in a moment, we found an average of 6 degrees of flexion contracture. So it's one of those things where, depending on the reference that you look at and what type of range of motion that we're evaluating. Sometimes there's loss of that wrist extension range of motion and whatnot on the dominant side. We typically are using a bilateral comparison with those measurements. Just another word about goniometry is typically we look at about a 6 to 8 degree minimal significant difference between examinations with these particular tests. And while it's fairly reliable with goniometric testing, we know that it's a 4 degree change from treatment to treatment likely is within the significant difference of error within the actual measurement. So something to keep in mind. End feels about the elbow. This is something that comes from Syriax's work. Elbow extension is supposed to be a very bony end feel, and many times in an acute elbow, we'll find that it's either capsular or empty after a significant elbow injury. But we should feel an actual bony end feel when we look at somebody or examine somebody with elbow extension, their elbow extension range of motion. Elbow flexion is soft tissue as our forearm musculature hits our bicep and our elbow flexion musculature. Pronation supination should be a capsular type of end feel. And then if just for review, the normal end feels of the human body are bony, capsular, and soft tissue, as we see all three of them about the elbow. The abnormal ones are spasm, springy block, and empty. And obviously those are atypical when found. As far as accessory joint mobility about the elbow, we can evaluate at the ulnohumeral joint adduction and abduction, as well as distraction, and a medial and lateral glide. Those are at the ulnohumeral joint. Those are the actual accessory mobility that we can compare bilaterally to determine if there's hyper or hypomobility. And as far as the radial ulnar joint, we have a dorsal and a ventral glide, as well as compression and distraction. And we can evaluate the symptoms around the elbow by doing each of those particular manual therapy movements. Manual muscle testing, one of the gross measures that is used around the wrist and hand, obviously, is grip strengthening. And that's a very reliable measure, and it's one that can be done with a handheld dynamometer quite effectively. Most clinics have one. The proximal musculature we talked about yesterday, how to work on somebody or test somebody's portions of their rotator cuff from Kelly's study in '96. And as far as the distal manual muscle testing, just realizing that there's a positional variation of the forearm based on brachioradialis, brachialis, and bicep, depending on what position of forearm we place the forearm in relative to elbow flexion. One other thing about the extensor musculature, if you resist, according to Kendall and Daniels and Worthingham, if you resist over the second metacarpal, that's for the extensor carpi radialis longus, the third metacarpal for the extensor carpi radialis brevis, and over the fifth metacarpal for extensor carpi ulnaris. So they're all wrist extension, but depending on where we place our resistance, biases each muscle to a certain extent. It's very normal for unilaterally dominant athlete and very unilaterally dominant individuals like carpenters and people like that do a lot of one-sided work to have grip a dominance factor of even 10% or more. Normal individuals usually have about 5% dominance on grip strength. So we can expect, if you're evaluating somebody's dominant arm, we would expect the grip strength to be not just equal, but likely 5% or more stronger on that particular side. So palpation. As we palpate our own elbows, and we'll do this because you don't really need to do this in a lab setting, it's something you can do sitting at your own table. you look at the arrangement, and these are just some quick and dirty things that come from Bernard Mori and some of his work on clinical examination of the elbow. And the diagram that you see in the top right of the screen shows the elbow in complete extension. And you have, you guys say olecranon or olecranon?
Olecranon.
Olecranon, okay, so you have the olecranon, and then you have the medial and lateral epicondyle, okay? And they essentially, in an extended elbow, if you're seeing somebody that there's a suspicion of fracture or any kind of deformity, it's a very quick way that you can look at somebody from a posterior view and see if the elbow landmarks line up appropriately. So you've got the medial and lateral epicondyle and the olecranon. When you flex the elbow to 90 degrees, it forms an isosceles triangle. So a lot of people don't remember what an isosceles triangle is, but you can see there's a very equisided triangle that goes between the olecranon and the medial and lateral epicondyle. So the relationship changes based on if you have the elbow in complete extension and flexion, and that's a very quick way that you are able to evaluate those positions for fracture, for prior injury, bony abnormalities, things like that. As far as the medial side of the elbow, if you palpate your own medial elbow sitting at your chair, you obviously have the medial epicondyle, and as you go posteriorly to that, you can feel and palpate your ulnar nerve, particularly if you relax very well. Some people have a very robust and thickened ulnar nerve. Some people have a very mobile ulnar nerve, and some people have very sensitive ulnar nerves that even as you do light palpation, they'll tell you that you have paresthesias in their fourth and fifth digits. You can feel the bony groove that the ulnar nerve flows in or follows through, as well as you can palpate the medial ulnar collateral ligament that goes from the medial epicondyle to the ulna, and then obviously the medial epicondyle itself, and that's where we have the flexor carpi radialis and the pronator teres of most interest inserting. Laterally, we've got the radiocapitellar joint, and then obviously the mobile wad of 3, or the mobile wad, extensor wad, whatever word you want to use to describe it. And we'll talk about the specific palpation on the lateral side, which is more discreetly described in the literature by Boyer and Hastings, as well as Greenbaum from some of their classic works. So the orientation on the lateral elbow, if everybody puts their lateral elbow in front of them, you can actually feel where the extensor carpi radialis longus, that's the top extensor muscle as it comes through the mobile wad of 3, or the extensor wad as it's oftentimes called. And the extensor carpi radialis longus actually inserts on the lateral epicondyle, but on the very most superior aspect of the lateral epicondyle, and then along the supracondylar ridge of the lateral supracondylar ridge of the humerus. So if patients oftentimes, as a small subset, will have tenderness up on the lateral supracondylar ridge, that's usually the extensor carpi radialis longus, not the brevis. We know from literature from Dr. Nerschel and others that the extensor carpi radialis brevis is the most prominently involved tendon in lateral humeral epicondylitis, whether it be in tennis players, day-to-day functions, and other types of occupational overuse situations. So where exactly do we palpate then the extensor carpi radialis brevis? That's directly on the medial epicondyle, and I'll talk about how to find that better on the next slide from Greenbaum. And then underneath that, or below that, are the extensor digitorum communis, and then finally the extensor carpi ulnaris. So it follows that distinct pattern that we can palpate very nicely and very carefully when you look at the screen and you see how you follow the tendon along the lateral epicondyle. So the extensor carpi radialis brevis origin is on the anterior aspect of the lateral epicondyle. And if you want to think of the lateral epicondyle of almost being shaped like a pyramid, it's somewhat pyramidal in its shape. It has an inferior slope, a superior slope, which then goes into the lateral supracondylar ridge, as well as then a lateral and medial slope. The medial slope, the anterior and medial slope of the lateral epicondyle is where the extensor carpi radialis brevis actually sits. And so it's a very easy way to palpate. Here's a little picture of the pyramid. A very nice way to palpate the extensor carpi radialis brevis is just going on the lateral epicondyle and coming just slightly anterior and medial to that and pressing distinctly there. You're directly over the extensor carpi radialis brevis. It's always a bit impressive to the patient when you can go up directly to somebody's lateral epicondyle, and again, 80% of the time, as Nerschel and others have taught us,
the ECRB is our tendon of primary pathology. If you go right up to that spot, you gently feel the lateral epicondyle and then fall off that anterior and medial ridge and press straight down. Again, 80% of the time you're going to be right on that spot, and they're just amazed, like, wow, you found that so quickly. We found it so quickly because we know the anatomy. That's the point. That's usually the point of exquisite tenderness, is where the tendon delves into the lateral epicondyle itself. So it's the most easy one to find, is on that anterior and medial ridge of your lateral epicondyle. On the medial side, they have little tricks that you can actually put your opposite hand over your elbow, as you see pictured here, and you kind of see how the superior most muscle tendon unit is the pronator teres on the most superior aspect of stemming off the medial epicondyle. Then you go to flexor carpi radialis. Then you have palmaris longus and flexor carpi ulnaris. The ulnaris is always the lowest one away from the medial and or lateral epicondyle, whether it's extensor or flexor carpi ulnaris. And then you see the same derivation. You have the anconius being the most superior on the lateral epicondyle, coming off over the top there, just like you have the pronator teres on the medial side. So pronator teres and anconeus are similar in that they're the most superior most aspect of the musculature coming off those particular structures. And then you see the extensors lined up, as we've talked about frequently. So this is the way that you can very carefully examine the tendons around somebody's elbow, and I think it helps to be very discreet as far as exactly knowing where they're maximally tender. Is it on the lateral supracondylar ridge? That means ECRL, extensor carpi radialis longus. If it's on that epicondyle, the anterior medial slope, it's definitely extensor carpi radialis brevis. If it's down inferiorly, you're probably suspicious of the extensor carpi ulnaris. So let's talk some about the special tests. And what we'll do, for the sake of this being videoed today, is we'll talk about these particular exam maneuvers, and then we'll have this on the screen as we go through the lab, so that we can just film the lab all at once with the lights on, filming somebody can hold the camera and do a nice job. That way everybody will be able to see the elbow examination. So we're going to talk about Tinel's test, which is a simple test for ulnar nerve irritability, which I think we all know. Some ulnar subluxation, ulnar nerve subluxation tests, and then some medial ulnar collateral ligament tests, valgus extension overload test, and then varus stress test, radiocapitellar compression test, elbow flexion test for the cubital tunnel retinaculum, and some of the extensor provocation tests of the elbow. So Tinel's
a quick question.
Yes.
So when you just talked about palpation as sort of, being able to figure out which tendon might be tender. Do you tend to use that more than manual muscle tests to tease out which extensor is fired up, or combination of, or?
Yeah, I would say I'd use the two together to corroborate. Yeah. So, if I manual muscle test extensor carpi radialis longus on the second, and they're palpably sore up above the epicondyle or the superior most part, I'm suspicious of the extensor carpi radialis longus. Now, if we want to be honest, we say, well, do you treat extensor carpi radialis longus any differently than extensor carpi radialis brevis? Because we're talking about less than a centimeter difference. Not really, but again, to be complete and to understand the structure, if I'm going to do dry needling or something like that, or I'm going to do something, then for sure I want to make sure I'm cognizant of what where am I going to find most of the pain and whatnot. So I think there's some value in being very descriptive with your identification, but when you get to, well, I'm going to do the Tyler twist, and I'm going to do some extension strengthening and whatnot, we aren't really specific about longus versus brevis in most of our applications. So it may just be to be more truly descriptive of what our diagnosis is. But I think you bring up a valid point. I think the two go together, and having good palpation skills and then corroborating that from a muscle tendon unit standpoint with your manual muscle test findings. So the ulnar nerve irritability, Tinel's test, we're just tapping along the course of the ulnar nerve, particularly along the ulnar groove. And most people know this is what? The funny bone. Oh, you hit my funny bone, I feel that. So you're just looking to see. What is important, and I might point out, which is, I think, known pretty universally, make sure you do the uninvolved side as well. Because we've all been fooled by the fact, like, oh my gosh, that really lit them up. But then you go to the other side, which is asymptomatic, and it lit them up too. Some people just have very sensitive and very proximal, superficial ulnar nerves. And if that's the case, Tinel's test is going to be very positive on it. It probably has nothing to do with the pathology that you're looking at. Ulnar nerve subluxation test. Does anybody in the class have a known? You do? Okay,
Hi.
so a couple people, so we'll be able to practice on them. But yeah, it's pretty easy to get. Sometimes the patient can just do it themselves by extending and flexing their elbow. One way to try to provoke it in some way, if you want to think of it that way, is to do what I'm doing here, where the patient is laying supine. They're in kind of a 90-90, extra rotation, 90-degree abducted position, and you basically extend the wrist and supinate the forearm, and then just kind of put a little tension on the nerve to see if as you go, typically it's in that zone between 60 and about 45 degrees where you'll just notice it blip. You can't really push or palpate it too much because sometimes just a simple palpation will hold it in place. So if you do hold or try to feel for it, make sure that you're holding very gently so that you don't actually block the nerve coming over the medial epicondyle. What about the ulnar collateral ligament? Obviously, with all the talk about UCL reconstructions and whatnot, this is something of great importance. It's very oftentimes difficult to identify somebody with subtle versus more pronounced ulnar collateral ligament laxity, if you will, or a full-blown tear, simply because the elbow is inherently very stable because of the bony makeup of the elbow and whatnot. So we rely, once again, on MRI and MRI with arthrogram, the T sign, and some of those things to be able to identify subtle pathology on the ulnar collateral ligament. However, I think this is a test that still should be done. One little gross measure of putting loads through the ulnar nerve, we can do this together, is the good hands test. And that's simply just putting your hands sort of like you're in good hands with Allstate kind of thing. That's why we now called it this. Patients routinely, baseball players would routinely tell us what makes your elbow hurt. And they would go like this and put the ulnar borders of the hands together like this, and it would provoke pain along the ulnar collateral ligament. And then those patients would go to get an MRI and ultimately find, hey, they have a torn ulnar collateral ligament. So we associate that not as being predictive, but something that goes along with irritability of the ulnar collateral ligament, be it a full or partial tear. And so it's a nice thing. The elbows are relatively extended. We also have on a flexor tendon side, the temple test. And this is very similar to this. I don't have it listed, but Dr. Andrews and his group a lot of times would have players come in and say, this is what really hurts, and they'd have a flexor tendon tear. And this would really, really set their elbow off. It'd be in full flexion as you see here, and they would press against their temple. So the good hands test and the temple test are two little provocation tests that are oftentimes, I guess we learned those particular maneuvers from our patients saying, this is what makes my elbow hurt, or this is what makes my elbow hurt. So they're not really special tests that you'd look up in a book. Those are tests that through the years we've begun using because our players have kind of taught them to us as being indicative of pathology. The milking test is for the ulnar collateral ligament, specifically the posterior band because the elbow is flexed. We know that the anterior band is the most active in the lower levels of extension because of the position of the anterior band of the ulnar collateral ligament. As we flex beyond 60 to 90 degrees, the posterior band of the ulnar collateral ligament is very, very active or very taut, limiting valgus stress. So the milking sign or milking test is nothing more than basically a valgus load in elbow flexion. We can have the patient do it themselves. Some people can't do it because they're too tight across their chest. But ideally, you start by adducting your shoulder and then reaching across and grab the outside thumb and then just doing this. And so if the patient can't do that themselves, just about everybody here in the class can do it. If they couldn't do it themselves, you as the examiner would simply cradle the elbow, grasp the thumb, and just pull them, and it's like milking, like you're milking a cow kind of thing. That's why they call it the milking test or milking sign, is that you're gonna make those subsequent valgus stresses looking for provocation. You're not noting the laxity or the amount of movement or anything like that. You're simply noting the presence of pain in the medial on the medial epicondyle, but most likely following that inferior and distal course along the course of the ulnar collateral ligament. So that's the milking test.
Todd, does shoulder position matter? Because I think I learned it back here, but maybe I just learned it wrong when you do it manually.
Yeah, and it's described in many different positions. You may be thinking of the O'Driscoll, which is the moving valgus test. That's done in abduction, and then you're actually doing an overpressure, not with the thumb. You could use a thumb, but where you actually go through a certain range of motion while you do an extra rotation stress to get the load. So I don't know if that's...
I learned milking back that
You
way
use milking
too,
back that way?
I just don't know if it matters.
Yeah.
It does tend to get the shoulder more involved.
Yeah.
It might muddy the water a little bit.
You couldn't do, the patient couldn't do it themselves back here, obviously, you'd have to
Correct.
do it on them, but I don't believe it matters with the shoulder, and it may just be, again, variations that
If
people
you would
have
do
used.
it here, if
So-
you were doing a milking test.
Yeah, I would typically do it either scapular plane, or if the patients do it themselves, they have to kind of be in the sagittal plane doing
Okay.
that. So valgus stress test, typically it's done in anywhere as little as 10 degrees of elbow extension or as much as 20. The reason that we're using just a little bit of elbow flexion is we want to unlock the olecranon from the olecranon fossa, because if there's too much bony stability, it may actually negate a possible positive finding, because there's basically very little laxity in a fully extended elbow because of the bony constructs. So by flexing it about 15, 20 degrees, you start to activate more of the medial and medial lateral ulnar collateral ligaments as far as doing our varus and valgus stress testing. So with a valgus stress test, we're testing the anterior band of the medial ulnar collateral ligament. And you don't want too much elbow flexion, because if you do, then it actually becomes just internal and external rotation of your shoulder, and we don't want that. We're noting both the degree of opening of the elbow as well as pain provocation. And again, don't get hung up on the amount of opening, because I'll show you some numbers from a stress radiography study that we did, just like we did that shoulder study I mentioned yesterday. We actually did, before we did the shoulder, we actually did an elbow stress radiography study to look at medial elbow laxity in professional baseball players. And I think the amount of laxity will kind of shock you as far as how small the amount of actual motion is with tests like that. Dr. Conway, who's from Dallas, has popularized doing the valgus stress test in the cornal plane rather than doing it out in front. Because if you look at the last slide, and we'll do this together in the lab and we'll film it so that you guys can see this, but typically it's done off slightly to the side of the body or directly in front of the body, and there's a lot of motion of the shoulder in that position. So Dr. Conway recommends actually doing it standing beside the patient. So you're actually doing it in the cornal plane, and that helps with opening up the elbow, or basically isolating the opening at the elbow and minimizing the amount of shoulder motion that occurs with this particular test. So that will be one variation that we'll do together in the lab, just testing, comparing, they're doing it in front of the body or directly off to the side. This is a study that I mentioned a minute ago that we did with the Milwaukee Brewers, looking at medial elbow laxity. And we had 40 healthy, uninjured players, 21 years of age, average professional pitching 2.76 years. Started pitching at the age 10, so these guys have been playing and pitching a long time on average. And this is the little device, if you look up on the screen, that we use. It's a stress radiography device. It looks fairly daunting, but it actually isn't. It's just a device that allows you to put the elbow in about maybe 10 to 20 degrees of elbow flexion, same position we do a valgus stress test maneuver in, and then you dial in, using a load sensor, you dial in a certain amount of valgus stress. And what you look for is the position at rest, which is D0 on the left-hand side of the screen. That's the position with zero load applied to the elbow, and that's the distance from the distal ulna to the the distal humerus to the proximal ulna, that distance. And then you put 15 kilopascals of force in, which is about 34 pounds. See right there, DAN is kilopascals. 15 kilopascals of load, and then the radiologist would read the difference between no load and the opening that's at the medial elbow. So that's basically what we saw. And what's interesting is how much of a load or how much opening did we actually see is an opening of 1.20 on the dominant side and 0.88 on the non-dominant side, which was significant. It actually was statistically significant as far as showing a difference. But at the end of the day, the difference between the elbows is not humanly perceptible. It's 0.36 of a millimeter. So that's a very, very small difference. So when you feel a baseball player, you examine a baseball player's elbow, there shouldn't be any significant difference between the dominant and the non-dominant side. They're essentially congruent, just like we would expect it to be congruent on a normal, healthy individual who isn't an athlete. So we found that the primary finding of that study was that there was no difference side to side that was clinically perceptible. Again, 0.36 of a millimeter is not something we can expect our hands to feel. So objective elbow laxity measures show greater medial joint opening on the dominant elbow in professional baseball players with no history of elbow injury. However, that increase in opening is not perceptible. It's such a small amount of increase. You could expect some increase, but again, not something that we're likely to feel. One of the problems with doing it manually, because that was another part of the study, is we also did manual assessment. There was no correlation between the amount of actual opening that we saw at the elbow and the grading that we did as physical therapists looking at the elbow. So it's very, very difficult sometimes to evaluate ulnar collateral laxity and whatnot, but we do have a very good clinical test in place, which is the ulnar collateral ligament or the valgus stress test. Another important test that's done is what's called valgus extension overpressure. And what I've tried to do with this particular presentation is not just talk solely about the actual clinical tests, but also talk some about the pathologies that we're looking for. And so one of the things that we see in throwers and tennis players and people who do explosive type movements with their elbow is something called valgus extension overload injuries. And we have two different types of valgus extension overload injuries. We have medial traction injuries from the valgus load, and we have lateral compressive injuries. So that would be on the radiocapitellar joint on the lateral side of the elbow. When we have a valgus load while it's being extended, we actually load the bony structures on the lateral side. And this can be particularly damaging to young individuals with open growth plates and people who can't tolerate that kind of compressive load. So many times when you see a young thrower, we oftentimes want to focus on the medial side, looking for laxity, looking for tenderness along the medial epicondyle or the ulnar collateral ligament, something like that. But many times we want to make sure that we're also asking about the lateral side, because with some subtle increases in medial laxity, we also see increases in compressive loading on the lateral side. And this can lead to things like osteochondritis dissecans, Panner's disease, and these osteochondral injuries that actually have pretty severe ramifications for an individual's elbow. So it's particularly young individuals. So the valgus extension overpressure test is a way to simulate the loads that somebody has on their elbow when they throw or when they serve or they do some type of an explosive motion. So this is the valgus extension overpressure test. Essentially you have the elbow in about 90 degrees of elbow flexion, maybe a little bit less if you wish, and then you impart a valgus load through the elbow and then rapidly extend the elbow to full extension. And you're looking for provocation of pain, typically in either the medial side of the elbow from the elongation or the traction, the lateral side of the elbow from compression, or possibly most importantly, in the posterior aspect of the elbow from posterior or bony impingement of the olecranon in the olecranon fossa. So you would do 1 or 2 repetitions. Again, if it's very positive on the first repetition, you probably don't gain anything from doing it a second time, but I would bounce it once or twice to try to give them a healthy kind of contact in the posterior aspect of their elbow and give them a healthy dose of a valgus load with extension. The moving valgus test for the medial collateral ligament was popularized by O'Driscoll. And O'Driscoll talks about the importance of, or the difficulty of the valgus stress test. And so he came up with this moving valgus test, which he uses quite extensively. This is all for the medial side of the elbow. It's always fun to go on vacation with me because this is in Rome, and most people probably walk right by this, but this is like a giant chunk of a statue that just is an elbow, and I'm palpating the medial epicondyle. So that's, you got to do that. You can't. How many times do you get to palpate a medial epicondyle that's that big, right? So anyway, that's all good fun. Anyway, here's the moving valgus test, and it's similar to what Randy was talking about a little bit ago in the position that he was talking about with the milking test. And it's nothing more than putting somebody in abduction external rotation. And as an examiner, you do an external rotation overpressure test on that individual's elbow, starting from 120 degrees of flexion, which you say, why 120? Well, that's where the elbow is during the cocking phase of throwing, all the way through near full extension. And O'Driscoll talks about this shear zone between 120 degrees and basically 70 degrees, where there's a substantial amount of stress on the medial ulnar collateral ligament. And that's usually the point in the range of motion where people feel that they have discomfort or feel that pain medially. And this is just a bit of an algorithm which O'Driscoll came up with, just showing that people who have symptomatic moving valgus tests, many times on clinical evaluation and subsequent arthroscopic evaluation, have tears, either partial or full tears, of their ulnar collateral ligament. And this is this shear angle or shear zone, if you will, looking at the test. And this is O'Driscoll doing the actual test on a throwing athlete, as you see in the top right part of the screen. Full external rotation, overpressure, which loads or creates a valgus load on the elbow, and then the elbow is moved from 120 down into full extension. And the most cogent part, or the most significant part of that range of motion, as you see on the screen, is that middle range, so roughly about maybe from 70 degrees all the way up to about 120 degrees in that range of motion. So that's an area. So 90 degrees abduction, modest valgus load, and you continue on to almost minus 30 degrees, and you can repeat it several times to look for discomfort. What makes the test positive? Pain generated must match the pain felt during throwing in the medial elbow. So if it's a different kind of pain, that's not a positive moving valgus test. Although pain may be felt through a range of motion, it must be between 120, late cocking, and early acceleration, 70 degrees. So that shear zone that he talks about. How good is the test? Well, the specificity in O'Driscoll's article in American Journal of Sports Medicine is very good, 75%, and the sensitivity, 100%. So the sensitivity to rule out ulnar collateral ligament pathology would be very good in the screening test for professional or all levels of baseball players and upper extremity throwing athletes and whatnot. So very good sensitivity, and the specificity is also very high, 75%. Bounce home test. What's a bounce home test? That's when you just take the elbow in neutral and then bounce it into full extension. And you should feel that bony end feel. And for most of us, as we do that to ourselves, that should not be a test that is positive or painful. That's something that should be pain-free on most individuals. And if it is, we would again be thinking about posterior osteophytes, because we get osteophytes that develop in the posterior aspect of the elbow along the margins of the olecranon that can complicate range of motion and elbow function as well.
Todd, I have a question I should know the answer to, but I just don't. So I always wonder this, and I think it's the first time I've ever been in a position to remember to ask. So olecranon bursa obviously is on the olecranon. What else is posterior? Is there fat pad, bursa, near the tricep attachment or deep to it, or what else is?
Yeah, the main thing, you've got, obviously have the olecranon bursa, which is down here. The main thing is your tricep tendon and a lot of aponeurosis around the tricep tendon,
Yeah.
and that actually comes into your olecranon. So those are the main structures. Unlike the knee, where you have fat pads and some of that stuff, and some of the structures that come out when you come into extension, I'm not aware of any fat pads or extra structures that are there. And that's why sometimes people do with hyperextension incidents, either in athletics or repetitive, like industrial things and whatnot, where they're repetitively extending their elbow, particularly over time. If there's any kind of bony abnormality, they can very quickly develop pain in the posterior aspect of their elbow. The good news is those are pretty easily managed. When I say easily, not with therapy, but via an arthroscope, where they scope the elbow, take out the osteophytes, trim, give smooth bony surfaces, and then get them back into full activity. It's a pretty straightforward procedure, which we see from time to time after elbow arthroscopy.
I just wondered that because those patients who get that posterior pain with extension and their triceps tendon isn't palpably tender, I'm like, what else is it capsular getting pinched, or is it just the fact that they're sort of banging their olecranon into the fossa that's causing that?
Well, I think additionally, some people would talk about not so much the capsule, because that's a bit exterior, but synovium. If you have a pinch of the synovium, or the synovium, a little hypertrophic synovial response, the synovium gets thickened, almost like in the knee where you have a plica. I have seen descriptions of people having symptomatic synovial thickening and whatnot that gets pinched and proliferative and can block and become pinched in elbow extension. So that would be one other structure that's there.
Yeah, it always felt to me in some of those patients, it felt like something soft tissue was
Blocking
getting
it.
impinged there. I'm like, well, it's not the tricep tendon, it's out of the way.
It could be the synovium
What else
and
is
something
there?
like that.
Right.
Yeah. Talked a little bit about valgus stress. What about varus stress? The trick question on most physical therapy exams or anatomy exams would be, what are the primary structures that limit varus stress of your elbow? And the ill-advised anatomist would essentially say, oh, it's got to be the radiocollateral ligament, right? You've got your ulnar collateral ligament, it's got to be the radiocollateral ligament. And the radiocollateral ligament really isn't a very strong, robust ligament. It comes off the lateral epicondyle, but it actually inserts into your annular ligament. And so it becomes a confluence with the annular ligament, which then really has a very non-optimal linear relationship with the lateral, with regard to protection of the lateral elbow. So you say, okay, Mr. Smarty Pants, what's the main structure on the lateral aspect of your elbow? It would be the lateral ulnar collateral ligament. So that's why a lot of times it's not really appropriate or descriptive enough to just say, oh, it's an ulnar collateral ligament issue. It's the medial. If you want to be really technical, we've got a medial ulnar collateral ligament and we have a lateral ulnar collateral ligament. And I think it's really important to essentially differentiate between those two, because one is for medial support or valgus support of the elbow, and it's on the medial side, and then the other is lateral, and it's our primary our primary varus stabilizer of our elbow. Just a couple more exam on the lateral elbow. Radiocapitellar compression test. This is a manual therapy type tool that can be used, or test that can be used, where you're suspecting lateral elbow pain, and particularly in a young thrower, as I mentioned, when you have that valgus extension overload injury where you have gapping on the medial elbow and compression at the lateral elbow. What you can basically do is you can extend and radially deviate the wrist, which loads the radius. And when you load the radius, it basically gets an axial load through the radius that then causes compression at the lateral radiocapitellar joint. And then what we're doing, once we load, we extend and we radially deviate, we basically then do a scouring type motion using the heel of our hand. So we palpate, if you look at the picture, I got my left hand on the bottom of her elbow, and I'm actually palpating that, and I'm feeling for any crepitation and grating that's reproduced when I do the loading at the radiocapitellar joint. Obviously, symptomatic response, just feeling some crepitus wouldn't tell you that much, but if that crepitus and grating is symptomatic, that would be a substantial cause for further evaluation to determine and rule out osteochondral injury in the lateral aspect of the elbow. So we'll actually demonstrate that or perform that in the lab together in a moment's time. Elbow flexion test. This is for the cubital tunnel retinaculum, and the cubital tunnel retinaculum is that sheath that lies over your ulnar nerve, and it spans the ulnar groove on the medial side of your elbow. It's sort of like a tent, if you will, and it's what helps to keep your ulnar nerve from subluxing. Some people have a very underdeveloped or maybe a traumatized cubital tunnel retinaculum, where then the ulnar nerve is free to pop in and out of the groove with elbow motion. The cubital tunnel retinaculum, as you see in the diagram on the right-hand side of the screen, the cubital tunnel retinaculum actually becomes very taut when you flex the elbow, but it becomes very lax as you extend the elbow. And so the idea, or the limitation, is that if you have swelling or irritation of your ulnar nerve or the structures in the groove, that when you repeatedly flex your elbow with tension on your cubital tunnel retinaculum, that can cause compression of the ulnar nerve. And so what people report to us subjectively, patients report to us, is things like they can't talk on the phone. Hello? You know, they're talking on the phone, and if they keep their elbow flexed for an extended period of time, they start to have ulnar distribution paresthesia, secondary to the compression by the cubital tunnel retinaculum. As you see, when the elbow is in extension, there's a great deal of, or a greater amount of laxity in the cubital tunnel retinaculum, and so somebody in full extension wouldn't have the ulnar paresthesias, but they would have it in flexion. So the continuous elbow flexion test basically is just that. You put the elbows, you flex the elbows maximally in front of you, you extend the wrists as you see here, you supinate the forearm, which puts tension in that area, and you have them assume that position for a minute or two to see if that replicates their symptoms. Simply knowing that something like talking on a phone for an extended period, or they'll tell you if they do that, would maybe negate doing this test, but if you want to see it happen in front of you, this is the test that we would do. Provocation tests. These are nothing more than manual muscle tests, really, but we're doing it to provoke specific tendons. And so our knowledge of where to resist for the extensor carpi radialis longus, extensor carpi radialis brevis, and the extensor carpi ulnaris, as well as flexor carpi radialis and pronators and supinators, allows us then to determine if doing the manual muscle test provokes pain in that particular muscle tendon unit. There are a lot of different tests described, Cozen's test, tests where you lift up chairs and different things, or resist the middle finger and whatnot for humeral epicondylitis. Those are all examples of provocation tests, and there's many variations of those, whether you want to resist at the wrist, the finger, however you want to do that. Like I said, there's a very wide variety, but they would fall under the umbrella of what we would call a provocation test, elbow provocation test. So what's key to remember is to examine with the elbow for provocation, to examine the elbow both in an elbow flex position, which is less stressful to the elbow tendons, the tendons that cross our elbow joint, as well as assessing them in full extension. Because to play tennis and to do many sport activities, you have to be able to extend your elbow nearly fully and have very good confident support in your elbow, forearm, and wrist. And oftentimes, someone will be asymptomatic with a provocation test in flexion, but they'll be symptomatic in extension, as you see here on this picture. So it's very good to know whether they have pain in flexion or extension with the provocation sign. So, any other questions before we head into the lab on elbow testing?
A provocation we do is a dynamometer with an elbow flexion extension, and some of the literature says do it. Pronation is most stressful, and some of the literature says elbow extend to the
Yep.
side. So
I've seen it both ways,
Okay.
exactly. And you make sense because when you pronate, you're slightly lengthening the lateral structure. So if you're trying to promote the lateral structures, it would make sense if they're gripping this way versus gripping this way, that would make a difference. Which do you do?
I usually do extended,
Yeah.
at the side, but not with pronation. I just didn't know if there was one particular test that
No, it's-
specific or.
I've seen it both ways, and even with JMAR, the JMAR hand grip dynamometer is probably the most popular dynamometer around the country and stuff. Beach Call in the 50s published like one of the first grip dynamometer studies and stuff. I remember reading that, 1954, I want to say. But nonetheless, very old classic study. And that was where they talked about protocols for it. And I've seen it both in the literature with your elbow down at your side this way and your hand in this position here or different positions here. I think, again, just like we talked about shoulder range of motion into rotation and stabilizing the scapula, I think it's really key that among whoever you work with that you do it the same way, because there is a subtle difference. And I've seen studies that show grip strength here versus here is different. I'm sure it would be a little bit different here. And so you want to be consistent in how you do it so that when you do your test retest, that it's a real valid measure of what you're looking for to change over time.
I will say in athletes, though, the few that I see, because I don't see much elbow stuff, because you guys see all of it, but in athletes, I'll always test them bent and straight, because a lot of times they won't feel it, just like you were saying
Yep.
before. They won't feel much at all flexed, but you put them extended and they immediately drop 20 pounds on their grip test.
It's a lot easier. And when somebody's healthy, there's not as big a difference. So
Also, goniometry-wise, when you're measuring extension, do you
Yes.
like to measure neutral or pronated or supination, or do you do all three?
I measure supinated, and that's just the protocol that I've used. My normative data sets are like that. I measure wrist flexion extension in pronation. Again, just that's the way I've always done it, and it doesn't mean it's right, but the key is consistency. So if you read a study that I did
Yourself.
15 years ago, I'm measuring it the same way now. So I think it's key just to know, what are your landmarks, how are you going to do it, how do you always do it, that kind of thing. So I don't think there's a consensus in the literature of maybe the right way to do it, but you need to know that, if you publish your work or have it be, descriptive in any way, you just want to make sure you make a note of how you did it, because it does matter.
I was taught in PT school supinated,
Supinated,
and
yeah.
I
That's
have
how I
a
was too.
coworker who does neutral, and I'm like, it makes sense because
Yeah.
ultimately I've had patients that are different in
Mhm.
pronation, supination, so I was just curious.
Yeah, no, I think they are. Something as simple as forearm rotation, it
Right.
will change. It definitely change it. All right, well, why don't we pause that so you make that one video and see if it worked, first of all.